Today we're going to cover some important topics regarding the management of burns within the emergency department and critical care. A burn is defined as a coagulative destruction of the skin and related structures. The most common cause of major burn are flame injuries. However, burns can be caused by thermal, chemical, electrical and mechanical energy. The risk factors for burn injuries are broad and include low socioeconomic status, overcrowding, cooking with kerosene, generalised poor health and poor safety practices, and as a result, worldwide 90% of injuries occur in middle to low socio-economic countries. The skin remains the largest organ within the body. It's composed of multiple layers, including the epidermis, dermis, subcutaneous tissue and muscular layers. The outer layer is the epidermis, which is composed of 5 layers and provides key roles with protection. It can take up to 30 days for the cells to migrate from the basal layers to cross the stratum corneum, the top layer, prior to being shed. The dermis contains key structures including blood vessels, exocrine tissue, hair follicles and nerves, and therefore the epidermis cannot regenerate without the dermal tissue. The subcutaneous tissue provides key functions with shock absorption, heat control and energy storage. A burn injury can be classified according to the etiology, i.e. the cause, the area affected in the body and also the depth. So the depth can be further subclassified into superficial partial, deep partial and full thickness. Superficial partial injuries involve damage to the upper dermis and therefore the appearance of the skin is pale pink and moist. Conversely, full thickness burns result in complete destruction of the dermis, leading to white, non-painful tissue. The area can be classified according to a range of different methods: Palmer methods, London Bower charts and Wallace rule of nines. The classification of severe burns include a total body surface area of greater than 20%. It's associated with inhalational injuries, major trauma, chemical burns and high voltage burns. So major burns have a localised effect at the site of the injury. However, based on the degree of the burn, this may lead to systemic consequences, and these will be discussed later. The central site of the burn is known as the zone of death and coagulation. As you work out from the central site, this tissue is vulnerable, i.e. if not managed correctly with fluid resuscitation and wound debridement, there's a risk of extension of the area of cell injury and death. This dead tissue can release a range of inflammatory mediators, including prostaglandins, leukotrienes, reactive oxygen species, which can result in vasodilation and increased flow. As you move out from the central area, there's an area of recovery, so this tissue will recover over time. Severe burns can lead to localised effects on the skin, but also effects within the multi-system disease. These can be classified into A to E. Inhalational injuries can lead to airway edema, leading to airway collapse, increased airway resistance and increased work of breathing. Parenchymal injuries due to chemicals in the smoke can result in a range of effects from collapse, pulmonary edema to ARDS. Smoke can contain carbon monoxide and cyanide, which can result in their own distinct pathologies. The cardiovascular effects are variable, so in the first 48 hours, patients may experience reduction in myocardial function and hypovolemia, and following this, in hyperdynamic phase. There's always a risk of hypothermia and an increased metabolic rate, but also a range of metabolic effects including increased ADH, increased renin-angiotensin-aldosterone system activation and increased coagulation. There's also a risk of acute kidney injury, acute liver injury, ileus and stress ulcers. And finally, there's a range of psychological presentations. The presentation and management of a burns victim should be classified into A to E assessment. Airway and breathing. Apply 100% oxygen. C-spine mobilisation may be required if multiple injuries or trauma victim is suspected. An airway assessment is essential. Look for perioral or oral burns, changes in voice, hoarseness, stridor, which suggest turbulent flow within the airway and may suggest impending obstruction. Evidence of inhalational injury with associated toxicity from carbon monoxide and cyanide should be on your list. Cardiovascular. So 2 large bore cannulas should be inserted, a full set of bloods including CK, calcium, troponin and a group and save, and an ABG to especially check carbon monoxide levels. Fluid resuscitation is essential using the PARKLAND formula. This is defined as 4 mL multiplied by the total body surface area times by the patient's weight, which is the total body weight. This should be initiated if burns are greater than 15% in adults or 10% in paediatric populations. Warm, isotonic balanced crystalloids should be given. So within the first 8 hours, 50% of this volume should be given, and the starting time is when the patient initially developed the burns injury. And after this 8 hours, the further 50% should be given over the next 16 hours. Pain management may be essential, and ketamine is obviously an option to be used. Expose the patient, remove clothes, jewellery, control heat, and have a thorough burns assessment. A secondary survey may be ensured. The degree of airway injury can be estimated from multiple factors. The patient's history, in regards to the exposure to the burn, examination findings, investigations including the ABG and the carbon monoxide percentage, and further investigations from an ENT team, including a flexible nasal endoscope. The airway management should be based on these features. If the patient requires intubation, it should be a senior person with ENT present with a clear plan in place. We normally use an uncuffed ET tube which is sutured in place. The airway plan will be based on the patient's presentation, but may include a rapid sequence induction, but also an awake fibre optic intubation. Following stabilisation within the emergency department, based on the patient's burn surface area, they may be required to transfer to a specialist burn centre for surgical management and ongoing care. Surgical management can be split up into early and late. This may involve debridement, escherotomies and fasciotomies, in addition to later management which may involve excision and grafting and reconstructive surgery. The ITU challenges are broad and can be split up into a system-based approach. Airway and breathing. Ongoing respiratory support may be indicated with bronchial clearance involving nebulizers, BEL and physio. Cardiovascular. Fluid management is critical, especially within the first 24 to 48 hours, to maintain a balance of perfusion whilst preventing the complications of volume overload. Hence, goal-directed therapy by targeting an hourly urine output of 0.5 to 1 mL per kilo of ideal body weight. Regular fluid assessment is essential and may involve cardiac output monitoring. There's always a risk of fluid creep, i.e. giving too much fluid more than needed. Disability, pain control and psychological support are essential. Exposure, temperature control and metabolic. NG feed should ideally occur within 4 hours. This is due to the increased basal metabolic rate. There's a clear correlation between lean body mass and complications including infections and death. Infection control. The main cause of death in patients with severe burns is due to infection, and therefore infection control, topical antibiotics and surgical indications are essential. Prognostication is based on the following formula: age plus total body surface area plus 17 if inhalational injuries are present.